Hi there, today's topic is on vermiform appendix, which is clinically very important. So, location of appendix, it is located in the uh, right iliac fossa. So, the appendix is an intraperitoneal organ which is covered by root of peritoneum called as mesoappendix, and it is narrowest part of the intestine, and it is the narrow muscular tube which is attached posterior medial surface of cecum. Appendix is located approximately 2.5 centimeters below the ileocecal junction. So this is the ileum, this is ileocecal junction. So 2.5 centimeters below the ileocecal junction is the location of attachment of appendix. So appendix may lie in various positions. So it is intraperitoneal, we know it is covered by mesoappendix. 2.5 centimeters it lies below the positions of appendix. Retrocecal position. Retrocecal is the most commonest position. It is around 64% to 65%. Retro means behind the cecum. The appendix lies behind the cecum. And then pelvic is the next common with 32%. And few individuals may have subcecal position, means or subcolic or subcecal position, which is below the cecum. And in front and behind the ileum are pre-ileal or anterior juxta-ileal, and post-ileal, which is posterior juxta-ileal. Pre-ileal is 1% individuals may have this position, and 0.5% may have post-ileal position. Based upon the tip of the appendix to which it is directed, we can designate into different clocks position. So retrocecal or retrocolic, the tip is vertically upwards, 12 o'clock. Paracolic, 11 o'clock. Then splenic, pre-ileal and posterior is splenic directed towards the spleen. Then it is splenic position, 2 o'clock. Promontoric towards the sacrum, promontory of the sacrum, 3 o'clock. Pelvic, 4 o'clock. Then mid-ingvanum, 6 o'clock. Arterial supply to the appendix. It is from the appendicular artery. So here is the appendicular artery. We will see how it is getting originated. It gets first abdominal aorta. Abdominal aorta gives rise to superior mesenteric artery, which is the artery of midgut, and appendix is a derivative of midgut. So it is indirectly supplied by superior mesenteric artery. So it is superior mesenteric artery further divides into ileocolic artery. So here is the ileocolic, which is a branch of superior mesenteric artery, and ileocolic artery gives rise to a longer branch towards the appendix called as appendicular artery, which gives rise to postcecal and anterior cecal. Postcecal gives rise to appendicular artery. So that is the arterial supply of appendix. Venous drainage of appendix, it is drained into the posterior cecal vein. Posterior cecal vein, we can see the appendicular vein drains into posterior cecal vein. Posterior vein, cecal vein drains into superior mesenteric vein. Superior mesenteric vein joins with the splenic vein to form portal vein. So superior mesenteric vein, the blood goes into portal vein, and portal vein, it forms sinusoids in the liver and forms the central vein. Central vein drains into hepatic veins, and hepatic veins drains into inferior vena cava. So this is the whole chain of venous drainage from the appendicular vein and posterior cecal veins, superior mesenteric vein, portal vein, then hepatic sinusoids, central veins, hepatic veins, and inferior vena cava of posterior to the liver. Clinical considerations, two things to be noted. One is appendicitis, inflammation of appendix. So appendicitis usually begins with the obstruction of appendix lumen with a like due to fecalith or fecal concretion, and the lymph node or hyperplasia followed by distension of appendix. And clinical findings will be initially the pain in the umbilicus because it is referred to the umbilicus, and umbilicus is supplied by T10 segment. So appendix is also supplied by T10 segment, so that is the reason it is referred to the umbilicus, or it can be referred to epigastric region. Later the pain localizes in the right lumbar region, and the main symptoms could be like nausea, vomiting, anorexia, tenderness or to the palpation, and percussion in the right lumbar region. So here we can see the distended appendix due to the obstruction. Here we can see the obstruction, and a lymphoid tissue will get inflamed. You can see inflammation. So the appendix most important point to be noted is the McBurness point. It is the point of maximum tenderness. So usually if it is not treated, appendix it may lead to complication like peritonitis due to the rupture of appendix. Next we shall look about this McBurness point. McBurness point, it is if you draw a line joining the umbilicus and anterior superior iliac spine. So, and now you divide the line into 3 segments, and the junction between the lateral 1/3 and medial 2/3. This point near the right iliac fossa is the McBurness point. It is the site of maximum tenderness during appendicitis due to palpation. So the appendix is suspended in mesoappendix, that is intraperitoneal, and it is generally found in retrocecal fossa, although its position is little variable. So that's how we locate the McBurness point, very important clinically. So let's see a question now. True statement about appendix. Does not have mesentery, has tinea coli, develops from midgut, supplied by appendicular branch of ileocholic artery. So the answer is, we know it, cecal bud is from the midgut, that is the post-arterial segment of the midgut loop. So appendix is derived from the midgut. And second right answer is, it is supplied by the appendicular branch of ileocholic, which is in turn a branch of superior mesenteric artery. Okay, so and we know the tinea coli are absent, and it is having a mesentery which is called as mesoappendix. So these two are wrong statements and these two are true statements. So this completes the anatomy of appendix. Thank you.